brain tumors, today I'm just going to talk about mainly the imaging principles of how to integrate a brain scan, a brain tumor scan. So imaging of brain tumors, the reason for imaging is that to find out if most of the time people want to scan is to find out whether it's a brain tumor. So what makes you think of brain tumors? So firstly, it's a clinical cause. So if clinically presents with specific neurological symptoms, headache, due to either direct effects or indirect effects, some more initiated imaging. This is part of the investigative process. Now, brain tumors can present in many different ways. Headache is only just one of them. So the interesting thing about brain tumors, unlike breast cancer or renal tumors, there are so many different types of brain tumors you can get. So depending on which part of the brain is affected, that's eloquent enough. You may have all the different presentations. Okay, so headache is very vague, but you may have very specific red flags to make you think of a brain tumor. So brain tumors, even in the same location in a child and an adult, the differential diagnoses are quite varied. So knowing the location is very important in making a diagnosis. So for brain tumor diagnosis, it remains dependent on two things. One is the location, and two is the age. If you cannot identify the exact location of a tumor, it's very hard to make a differential diagnosis. Age is very important, so you will never really diagnose a medulloblastoma in a 70-year-old. Ependymoma can be in young, can be old. In children, glioblastomas are probably not as common as well. But today I'm going to talk mainly about the brain tumors. So how do you image a brain tumor? There are many different ways, but specifically there are two. That is CT and MR. All the others are not really in use. Okay? So CT is very fast and easily available. It's usually your main screen to make sure that there's nothing big in there. You've got a bleed, you've got massive and you've got hydrocephalus. But CT has very limited users. Apart from being able to identify things like calcification, cystic change, hemorrhage, bone destruction, you can't really tell very much. So MR is effectively the only way to investigate. MR is very good because you can scan in different planes. You can scan in sagittal, coronal, axial plane. And you can tailor the imaging technique to get maximum information from the scan. You can characterize the tissue because of the surface, hemorrhage, solid components, different products, pertinacious fluid. And new techniques are being developed all the time. So these are the sequences that we use for diagnosing brain tumors. There are a lot of variations in imaging techniques, but this is the protocol that I set up about in 2007 and 2008 in some of the whole Greater Manchester. They tried to state a fixed protocol. So axial T2 is very good for just generally looking for abnormalities because most pathology have some fluid and fluid inside in T2. It helps to highlight the abnormality. Flare is very similar to T2. It's just that anything that is pure fluid, the signal is suppressed. So it's good for periventricular abnormalities. T1 is very good for anatomy. And when you give contrast, you need to have a baseline for comparison. So you have a post-contrast axial T1 to allow you to directly compare what is enhancing. In all pathology, you need to look at it in two different planes to get three-dimensional approach there. So you need to scan in different planes. So coronal flare and post-contrast coronal T1 is the other one to use for assessing the lesion. So axial is good for front to back, side to side, but coronal is good for top to bottom. Okay. Now, diffusion weighted imaging is very important because you don't want to get caught up diagnosing a tumor and access as a brain tumor. And it also helps in various conditions like sort of lymphoma or very high-grade cellular tumors that will have some diffusion restriction. You will also avoid misdiagnosing a stroke, and it's also good for tumors like epidermal where it is quite intense diffusion restriction. But nowadays, in addition to all these sequences, you get a sagittal brain lab sequence or formation of the brain tumor. So these are the sequences that we use. I do not use XOT and XOFLAR because it's exactly the same thing. It has the same abnormality that FLAIR will show you just a little bit better. You're going to do a FLAIR in the coronal plane, in the orthogonal plane. So how do you evaluate a brain tumor? So there are a lot of questions you may ask yourself. Firstly, is there a brain tumor? And if there is a brain tumor, what is it? Is it inside or outside the brain? Where is it? Is it in the frontal lobe, parietal lobe, temporal lobe? What is relevant to your symptoms? If it is intraaxial, is it arising from the cerebral hemispheres or is it outside, as in from the region of the cranium? And what are the tissue characteristics? Once you've identified the whole lesion, you need to know what are the direct and indirect effects on the brain. So if it's blocking the CSF flowing like a hydrocephalus. And is there anything else other than brain tumor? So not diagnosing just one lesion is one thing, but you need to make sure that there are no other lesions to make you think of a differential diagnosis, complete diagnosis. So is there a brain tumor? So you look at all these three sequences, three images, three different patients. There's one lesion here, there's one lesion here, there's one lesion here. So this is clear cut. You look at it and say, this is definitely a tumor. This is solid, this is space occupation, it's not a tumor. But this one, is it a tumor or is it an infant? There's a low-grade glioma, glioblastoma, and meningioma. So all these three are brain tumors. So is there a brain tumor on this? So you have a pre-contrast and a post-contrast scan. And if you follow this, find that with bits that enhance the contrast, and so actually there are multiple lesions. These are the metastasis. So there's always a trend to ask a post-contrast CT scan when you see abnormality in pre-contrast to see whether there's any harm. And in my practice, personally, once I see an abnormality on the CT, I do not give contrast on CT and go straight for MR because MR tells you a lot more, gives you a lot more information. Even if you find one lesion, you think it's a metastasis, give contrast to identify that. When you do an MR, you might find that there are more lesions. You might even find things like meningeal enhancement that you will not see on CT. So it doesn't help you. If you see a necrotic lesion, you think you want to know whether it's enhancing, will tell you whether it's a tumor. And that's what you do exactly the same thing. They do tell you it's an abscess on that CT. So I tend not to do post-contrast CT in all my brain lesions. So where is the tumor and what is it? These two lesions are very, very similar. Yeah, we look at intraaxial lesions, but they're actually different. And in our role is to differentiate these two tumors. So this lesion on the left-hand side is anaplastic oligodendroglioma. So here. And that on the left is a meningioma. The way we tell it is that in this lesion, we find that there are what we call CSF clefts. And the lesion arises from outside the brain and pushes the brain inward. It pushes in the clear matter, it pushes in the CSF, and it pushes in vessels that interpose in the subarachnoid space. Okay. So that's one thing, it's inside outside. The next question is that which lobe is the lesion in? You find the lesion very much in the frontotemporal region. Is it in the frontotemporal? But in fact, you do not get frontotemporal lesions because what suffers of frontal and temporal lobe is a cervical fissure. It's either coming from the above, pushing the cervical fissure down, or from below, pushing the cervical fissure up. So by doing an axial T2, you still know why you're it. If you know your anatomy, that this is definitely a temporal lobe feature. Okay, pushing upwards. You can't loosely call it a frontal temporal because in order to get from the temporal to the frontal, you need to go through the insular cortex, go around the cervical fissure. That's why we do coronal imaging. If you look at cervical fissure elevated, you know the mass is expanding the temporal lobe and pushing it upwards. So in this case, this is a tumor. So localization of tumor is very important. If you see a lesion around the cranial region, you do not know where exactly it's coming from. These two look quite similar, and yet they're different. So a pineal region, we tend to call it a corneal region lesion until you do a partial sequence to identify where exactly the lesion is. In this case, the lesion lies below your great veins, the vena Galen. This is expanding the tactile plate, is a tactile plate tumor, whereas this round lesion is quite typical occurrence of the palpitotemporal meningioma, pushing everything away. Okay. So you look at these two lesions, they're intraventricular. Once you localize a lesion to the ventricles, then you limit your differentials to ventricular tumors. In this case, this is the triangle of the lateral ventricle, the typical location for intraventricular meningioma. And this lesion is in the left ventricle is squeezed through the foramen majority into the back of the foramen magnum, compressing this, and this is the tendinoma. It's an intraventricular lesion. But for those who are astute, you notice that there's another lesion up here, the meningioma. Okay. So once you localize the lesion to the corpus callosum, there are very few things that affect the corpus callosum. If you've got a tumor, you've either been a background glioma or so the lymphoma. So localization is very, very important. The other big lesion you can get in the corpus callosum is a giant MS plaque. It looks like a tumor-affected demyelination. So localization of the lesion is very important. Very few things pop in that line. So tissue characterization. So in CT is based on density. So if you look at this lesion and create a post-contrast scan, all the high density areas are either due to calcification of blood. Okay? The low density areas are either non-enhancing tumor or necrosis. And we look very, very closely between the two scans, comparing exactly the same image, you find that part of it actually enhances. One that enhances, it must be solid tissue, it cannot be anything else. Okay? So this lesion has some calcification, it's got some cysts, some necrosis, and the solid component to it that enhances with contrast. So CT is useful only for identifying things like calcification. So in this after case, you've got a cystic lesion with an enhancing nodule back here. This looks like a cystic lesion as well. Okay? They both look like cysts. This one is not. It's actually a higher solid tissue that is scalping the overlying calvarium. So CT only can go so far, but it doesn't actually tell you whether it's pure cyst, whereas MR can tend to give you a bit more information on that. So one is hemangioblastoma, the other is DNS. So tissue characterization. On MR, you find this is pure cyst, quite broad, low on T1, and there's an enhancing nodular edge. So based on all that and the location, you can look at diagnosis of hemangioblastoma. The other thing is that in this part of cyst, the cyst wall does not enhance, which is quite typical of hemangioblastoma. I'll show you examples later on how to differentiate. So this lesion from CT, T2, and post-contrast T1 gives you different information. You've got mixture of solid enhancing component, you've got tissue necrosis, you've got edema all around it. Necrosis is a good indicator of high-grade tumor. Now, we tend to call anything that is bright in the white matter edema, but in reality, they'll be very, very careful. Edema used to be quite bright and T2 in this flame shape. It just spreads all over into this white matter. But not everything is due to edema. If this is a glioma, all these changes could be non-enhancing tissue. So in the olden days, where people used to biopsy for this lesion, we find that beyond the enhancing lesion, all the areas of so-called edema on histology shows that actually due to tumor infiltration. So you can't really tell it's pure edema. Okay. Things with necrosis in it that looks ugly in a dark patient tends to be GBM, but metastasis and radiation necrosis can occasionally look exactly the same. Okay? So, contrast enhancement. In the brain, there's a blood-brain barrier. So, if things enhance, whether it enhances or not, depends very much on the integrity of the blood-brain barrier. low-grade gliomas, the capillaries are quite near normal, the functioning blood brain barrier is 10 meters in height. And malignant glioma, the endothelial cells are fenestrated, there's no blood brain barrier. Metastasis states possess non-CNS capillaries that there is no blood brain barrier, and most of the time it enhances. But I've seen metastases that do not enhance, so you've got to be very careful. These are not common, but they can occur. Okay? In meningiomas, almost all meningiomas are enhanced. Unless it's heavily calcified, you cannot differentiate that. But once you know there's a tumor, you know where the location of the tumor is, you need to know what you do with it, not in a direct and indirect effect. So you've got mass effect. In this case, the massive expanding temporal compressor in brainstem, the brainstem distortion. You've got midline distortion, subparcel herniation, and if there's bad enough mass effect here, it can also distort the optic chiasm. There's a mass effect. You get a pressure effect. So the slow growing, the lesion will slowly start scalping, eroding the calderon. So once you see this, you know that this lesion is probably slow growing and has been there for quite a while. But meningiomas, on the other hand, can actually stimulate bone reaction and get hyperostosis in the overlying bone. Sometimes the tumor can also extend through the bone with a transosseous extension, and the bone can become sclerotic, but also enhanced. Now, if it's compressing on the CSF pathway, it can end up with hydrocephalus. In this case, it's compared to fourth ventricle, you get triventricular hydrocephalus. And this primary region lesions compressing the back of the third ventricle, you also get triventricular hydrocephalus. Once you think the tumor is invading the brain with all the down and down effects, the next question is, can this be anything other than a brain tumor? So the brain tumor mimics that we try to avoid making mistakes on. The one is simple infarction. Okay. The way we diagnose infarction is based on the anatomical location, knowing that we lose great anatomical differentiation, and it affects the in the territory that is recognizable as a vascular territory. And to make a diagnosis of infarction, you need to know the arterial territories very well. Anything that's unusual, things twice with the pulmonary infarction. Now, this one is a young boy who presented with right-sided hemiplegia, and with a lung, he said that this was the brain tumor. That's what we really do. He said this standard brain tumor protocol with contrast in. And because our protocol includes diffusion with imaging, shows that this one turns out to be an abscess. Right? Diffusion trace, black on the ABC map. Okay? Fantastic abscess. This one also looks like a tumor. Young guy who presented with flat-sided hormonal hemorrhage. It's because of factory lateral body. And this young guy has a plaque of demyelination, which is incomplete ring of enhancement. Another tumor. So, back in 2000, late 2009, we went through all the tumors, presented the MDT, and found out what are the commonest tumors. All common things are common. If you know what the common lesions are, most of the time these will be the differential diagnosis. If metastasis, you've got meningioma, you've got low grade, you've got high grade tumor. Lymphoma is a bit underrated because we don't really think of it, but you must always think of lymphoma. If the imaging fits, you've got to be careful. Once you miss a lymphoma, you have to steroids, the lesion can actually shrink. All vivid tumors constitute a very small proportion of your daily practice. Okay? So this is Alvin I did from Manchester, our experience back in 2009. Localization of tumors is very important. So, like I said earlier on, every tumor, depending on location, is a different list of differential diagnosis. So I've divided the tumors into these categories. In hemispheric tumor, in the southern hemisphere, also fossa, ventricles, primary region, and supercellular, and they've got all tumors in different syndromes and mimics. Penetrate tumor, we first thing you want to know is it inside, outside the brain, intra-extra-axial. Once you get intra-axial, you get low and high-grade tumors. High-grade tumors are GBM, anaplastic gliomas, the metastasis, and lymphoma. Low-grade astrocytoma, oligodendroglioma, and a whole host of other lower-grade 1 and 2 lesions. Once it's extra-axial, once you localize it in extra-axial, majority of tumors are going to be meningioma. Occasionally, you will get during metastasis or lesions coming from the bone, like plasmacytoma, expanding the bone, going to the dura, and pushing the bone inwards, and then you think of lesions outside the bone, as things like bone lesions. So that's part of extraction. Get it out of the way. Big homogeneous hyperdense mass enhances homogeneous contrast in the periphery of the brain, compressing the brain. This can be meningioma. Convexing meningiomas and actually T2 can be very lobulated, can be really blind. It is a macrocystic meningioma. But once you give contrast, it almost always enhanced using it homogeneously. And they tend to push the brain inwards, like I said earlier on. When they push the brain inwards, what you're looking for are these clefts that push inwards. You can see a vessel interposed in between here in the brain tumor interface. It is also a good sign that the lesion is extra-axial. Meningioma can occur in many different locations. Apart from convexity, we can characterize meningioma. We can have a plain and sphenoidal meningioma. This is going into the cella, compressing the pituitary gland. We can have a sphenoid meningioma around the muscle of sphenoid. Sphenoorbital meningiomas are a problem because they can go through the bone and form an extracorneal mass compressing the orbital structures and end up with proptosis. We can have multiple meningioma.
Most of the time, the gliomas we talk about are the astrocytomas and oligodendrogliomas. They start off as grade 2, and as they progress, they become grade 3 and become grade 4. You can also get primary GBMs. They start off as grade 4, or secondary GBM. They start off as 1 or 2, and they start off at 2, and they progress to grade 4. Grade 1s are completely different beast altogether. Most of the time, your tumors are going to be gliomas, and of all the gliomas, about 50% of them present as blastomas. Metastasis is the other big group of tumors, and cerebral lymphoma is a much smaller group, but something you could bear in mind all the time when you're looking at tumors. So these are all the common intra-axial brain tumors. So let's start with low-grade astrocytoma. Low-grade astrocytoma tend to be an abnormality involving both the gray and white matter. They're hyperintense on T2, similar on flare. They tend to infiltrate the cortex, expand the gyrus, and they start infiltrating. And most of the time, they do not enhance. Second commonest, or equally common, is oligodendroglioma. Oligodendroglioma, in the past, the way to diagnose it, everyone talks about curvilinear calcification. But nowadays we see, because we scan patients so early on in their pathway, you find that some of them may not calcify because you catch them quite early on. But if you see all this curvilinear calcification, it's quite a good indication this is going to be an oligodendroglioma. Again, these primary tumors affect the gray and white matter. And the slight difference between oligodendroglioma and astrocytoma is that oligodendroglioma tends to cause a thickening of the gyral cortex. They look expanded. And sometimes on T1, you see this curvilinear high signal, and that on CT corresponds to those areas of calcification. Again, this is intra-axial, coming from the brain, is expanding the lobe of the brain. Now, these two lesions look very similar, and yet they're different. If you look at it closely on T2, this lesion is almost homogeneous. in T2 hyperintensity, whereas on this side, there's some gyral thickening. Look at it, on T1, it's more hypointense. On T2, this lesion tends to have this gyral pattern where the gyral cortex of less is sort of higher signal than the white matter bits here. So based on the imaging appearances, this is very much an astrocytoma. This is an oligodendroglioma. Now, this case back in 2007, 2008 created a lot of problems because, firstly, no one believed that these are two tumors. And secondly, they said these two tumors must be exactly the same. But we said, based on the imaging characteristics, these two lesions are different. We suggested that they biopsy these lesions. Now, some surgeons agreed, some didn't agree about whether you should biopsy this. So the reason for biopsying this is that we know that this looks an astro, this looks an oligo. Most of the astros eventually will turn into GBM, but the good thing is that this is in a non-dominant hemisphere. If this is an oligodendroglioma, they can respond to chemo and radio, and it's in the dominant hemisphere. So this is one you don't want to take out. So we proceeded to biopsy this, and this one turned out to be astro, and this one turned out to be oligo. And they treated with chemotherapy. This one shrank away. This one shrank a little bit, but eventually, whatever was left, this turned to GBM. The patient died from it. So, low-grade gliomas, almost all tumors will progress astrocytomas or oligo. And it is because of this nowadays, with good surgical technique, almost all low-grade tumors, when they can safely resect it, they will resect it. They don't wait till it progresses. Once it starts progressing, it goes up the scale from 2 to 3. But because they progress so quickly from 2 to 4, it's very rarely do we catch one that is transforming to grade 3. They tend to just jump straight to 4 by the time we catch it. But if you do surveillance imaging and you find that the lesion either changes in diffusion restriction or starts enhancing a little, those areas may be transforming. If you catch it, you're likely to catch it at stage when it's turning to 3. But once they start enhancing, at some stage, it's going to start becoming necrotic, and it's become a grade 4. So there's a progression. So this is a patient with MS, got multiple MS plaques, and each time the patient has symptoms, they rescan the patient, they look for more lesions. But there was a lesion here that didn't look like MS at all. And we said that this was low-grade glioma. And for years, this was called giant MS plaque. And we said this is a glioma. They confirmed it. And at some stage, this is a post-surgical scan. At some stage, it started transforming, became a grade 3, eventually became a grade 4. So lesions can coexist. So this is another low-grade glioma. Hyperintense on T2, no contrast enhancement, a bit low on flare, mass effect. And this was followed up for years. And one day, between 2 scans, 6 months apart, it turned into a huge GBM. Okay, so moral of the story is that all these low-grade gliomas eventually will turn nasty. So nowadays, what we tend to do is we try to get the maximum information by doing things like perfusion, looking for areas of higher cerebral blood volume that would suggest that it is of a higher grade, and target those areas with biopsy. And once it's safe to resect, the surgeon will resect it. And nowadays, surgical resections are so good anyway, and they can do it with surgery. They can do really, really well. Then, apart from all this astro and oligo, you have a bunch of all these low-grade lesions, a mixed bag of different lesions. So we show DNET, scallop in the bone. This is the same patient, the DNET. On T2 looks like fluid, and yet on flare, it's a solid tumor. On T1, it's low signal, doesn't enhance. And again, as you can see, a scallop in the bone. Now, this is a more typical appearance of DNET. The bubbly T2 hyperintense lesion looks like a bunch of bubbles, and they tend to occur in the mesotemporal lobe, affect the amygdala, can spread further laterally. is a very typical appearance. They tend not to enhance, but has been described in literature that DNETs can enhance. In fact, we have one ongoing NF1 patient that's got DNET that is slowly progressing each time. Bits of lesions start getting bigger and bigger, and one of them starts enhancing as well. Now the question is whether that's actually a real DNET, and that will be discussed in MDT next week, I think, to decide whether they need to be taken out. Now a DNET can also look like this. It can just be hyperintense on T2, just involving cortex. Flare, hyperintense on T1, low signal, it doesn't enhance. The difference between a DNET and this new lesion called a multinodular vacuolating neuronal tumor is that DNET tends to affect the cortex, whereas MVNT are little bubbles in the subcortical white matter rather than the cortex. If you have a lesion that looks like glioma or DNET, but it enhances it has got diffusion restriction, that's an epidermoid. This is an intra-axial epidermoid, quite rare, but is recognized. So we have about 2 or 3 cases of these intra-axial epidermoids, and the clue is diffusion restriction. And another very rare tumor is called PXA, pleomorphic xanthoastrocytoma. They tend to be a cystic lesion with mural nodule. They tend to abut the cortical surface, and when it abuts the tentorium, they can also incite a reaction. So based on imaging characteristics, a cystic lesion with a mural nodule, there are about 4 diagnoses: hemangioblastoma, PXA, ganglioma, and a, what's the last one? Pilocytic astrocytoma. Okay, so based on imaging characteristics. This is another low-grade tumor that looks nasty. It's got cysts, it's got enhancing components. This turns out a ganglioma. When you look at this, despite the size of this mass, there's absolutely no edema around this. So this has been there for a while. Okay. Then there's another lesion that looks like a low-grade lesion or calcified lesion with a lot of edema around it. And on CT, it looks like a chunk of bone sitting in there. And on MR, the chunk of bone is black, and there's a lot of edema around it. This is what I call a capnon. It's calcifying pseudoneoplasia neuraxis. It's a recently recognized entity. So these lesions, intraaxial lesions, are less common. Majority are going to be high-grade lesions. Glioblastoma is the commonest glioma. 50% of all gliomas will present as a glioblastoma. In an adult patient, you see a hemispheric tumor that's big, that's ugly, that's got a lot of massive involving cortical gray matter. If you make a stab at it and say it's a glioblastoma, most of the time you'll be right. It's quite a typical appearance, hemispheric tumor involving cortical gray matter, quite dense, and when you give contrast, it has got this irregular enhancement with areas of non-enhancement in the center. It's quite a typical appearance of glioblastoma. But glioblastoma can come in different guises. They can have irregular appearance, solid bits, irregular enhancement, and yet no edema around it. Look at this on CT. It looks just like a solid lesion with no edema, and all these areas are actually tumor on MR. See all this? This is all tumor infiltration, and it affects the cortex as well. And here, it shows that streaky enhancement. Again, this is a very typical appearance of glioblastoma. Now, this is another high-grade glioma. It affects the cortical gray matter, and yet the enhancement spares the cortical gray matter. And you have this bit here. We will usually people just call this edema, but in reality, this is all part of a non-enhancing tumor. It's different from edema, where edema tends to be flame-shaped. They just extend to gyral cortex. This has quite a well-defined margin to it. This whole tumor. Glioblastomas can also bleed because they're quite cellular. And in this case, on T1, pre-contrast, this hyperintensity is due to methemoglobin, this is all blood. Okay, all these areas are non-enhancing tumor. This is different from the edema here, which looks flame-shaped, extending into the white matter. And that's tumor, that's edema. Post-contrast, you see this bit here, it's all enhancing. These are the enhancing solid components. So never ever ever look at a post-contrast T1 without pre-contrast, because without a pre-contrast, you do not know what is enhancing. Okay, these are the areas of enhancement. This is all due to blood products. This one is a small focal GBM. Again, it shows some irregular rim enhancement, and we know it's a GBM because it affects the cortical gray matter. It's infiltrated the whole lesion. Okay, and this is a incidental meningioma. And this lesion is also a small focal GBM with very little edema around it. It looks almost extraaxial, but it's actually involving part of the gyrus that is expanded. So you can have a solid and very vascular GBM with lots and lots and lots of vessels in there. It looks nasty. But it also has been described that certain GBMs can have an AVM within it as well. I think we had 2 cases at Salford in the last 10 years. You can have a cystic necrotic GBM. This looks just like a cyst with lots of edema. And post-contrast shows very thin rim enhancement. So GBM is a great indicator of everything else. And diffusion-weighted imaging shows that this is free diffusion. Black on diffusion trace, brown ADC map. Versus an abscess, which is high on the diffusion trace and black on the ADC. Okay. Now, one thing about gliomas, they tend to infiltrate along the white matter tracts. You just follow the path. So in this particular lesion is in the parietal occipital region, towards the back of the temporal lobe. If you follow the next slide down, next slides down, you find the tumor actually is infiltrating the white matter, going across the corpus callosum to the opposite side. If you look at a coronal flare, you find that it's gone all the way across and it's infiltrating the mesiotemporal lobe. So you can almost expect where the tumor is going to go next. Next slides forward is tracking anteriorly along the mesiotemporal lobe into the hippocampus, into the amygdala. And on the same side, the tumor is also extending anteriorly along the mesiotemporal lobe to involve the amygdala. This kind of appearance can only be due to glioma. Nothing else does that. Actually contiguously infiltrate the brain. You look around here. Even here, there's signal abnormality going to the corpus callosum. Okay, only a glioma will do that. So if you look at this tractography, you know these are the fiber tracts: corpus callosum, corticospinal tracts going downwards. So you can follow the tracts. You find the tumors just infiltrate. So you can have a tumor in the parietal lobe. You can infiltrate down the parietal down to the temporal lobe along the back. Whereas if you have a tumor, in the frontal lobe, the only way to get from frontal lobe to temporal lobe is going across into the insula, down the insula, and down the temporal lobe. This is another one that infiltrates along the tract. So this is a deep gray matter, glioblastoma. It's gone down the temporal stem into the temporal lobe, and it's gone along the optic tract to involve the optic chiasm. And continue downwards along the brainstem into the cerebropeduncle. And subsequently down the right side of the brainstem, down to supracerebellar peduncle and towards the cerebellum. Only a glioma will do that. Now, gliomatosis cerebri is another extension of GBM. It is no longer an entity in WHO classification. So what we still use, I still use it mainly to describe the extent of the tumor. So gliomatosis in the past is used to be described as a overgrowth of neuraxis by neoplastic cells that tend to affect at least 2 lobes, usually 3. The contiguous involvement. The effect of grey and white matter can be just very, very diffuse signal abnormality. It can also affect the cerebellum, brainstem, and spinal cord. And there are 2 types, type 1 and type 2. Type 1 is when there's expansion of 2 or more lobes, but without an obvious mass lesion. Whereas type 2, you have the same appearance, but within this, there's a mass, a clear GBM. Okay, this is what it looks like. Almost like a diffusely infiltrating glioma. Whole of the mesotemporal lobe affected here. And on this side, the same thing. But you can track the 2 at the back going across via the spleen of the corpus callosum. Okay, and within this, there is a nasty component to it. Okay, metastasis. Metastasis are come from outside the CNS. You can have multiple lesions, but not all multiple lesions are metastasis. Metastases tend to seed at the gray-white matter junction, very similar to abscesses disseminated via the blood flow, the circulation. You tend to see it at gray-white matter junction. So you have multiple lesions at gray-white matter junction with surrounding edema, you're home and dry. Most of the time, these are metastases. And in the posterior fossa, if you see a primary intraaxial lesion in an adult patient, statistically, this is going to be a metastasis. And in this particular case, this lesion has quite a typical appearance of a mucinous adenosine metastasis, lobulated, black, almost like cauliflower, and they enhance poorly. And on T1, they can be almost iso-intensive brain, and on CT, they tend to be bright, tend to be dense. In fact, every time you see one of these metastases, someone will call it hemorrhagic metastasis or a primary ICH, but actually they're just hyperdense lesions. So, lymphoma. The importance about lymphoma is that once you recognize it, don't whack in steroids because they will disappear. Like I said before, there are 3 things that affect the corpus callosum: lymphoma, glioma, and tumor-effective demyelination. On CT, lymphoma tends to be homogeneous, hyperdense or isodense lesion. The locations tend to be around the ventricles or near where it can touch CSF, so on the surface of the brain, very close to the CSF surface. CT dense, homogeneous. T1, they're almost same signal as brain. On T2, they tend to be darker and they enhance homogeneously, and they also have diffusion restriction. This is another deep lesion abutting the ventricle, close to the ventricle surface, affecting the thalamus, hyperdense on CT with some edema. Post-contrast, it enhances homogeneously. Another one, periventricular lesion, low on T2, enhances homogeneously. Second lesion here. And after giving steroids, they shrink away quickly. Another one, dark on T2, involving deep brain matter, enhances homogeneously with contrast. With steroids, at 6 months, disappeared. This is slightly different. This is more peripheral, hyperdense lesion. T2 again is dark, lobulated, enhances almost homogeneously, extending to cortical surface. Second lesion in the cerebellum, enhances with contrast, again homogeneously, small patch. And the third one, the medial frontal lobe. So what are the diagnostic challenges? When you have a solitary lesion, most of the time you want to know is whether this is a metastasis or is a GBM. If you have multiple lesions that looks like tumor, you'll probably be quite safe this is metastasis. Even then, you can have multifocal gliomas. Deep white matter extends the cortical surface is one thing, commoner in GBM. Extent of edema, I do not find it helpful. You can have a big GBM with very little edema. You can have metastasis with no edema. But our institutional experience at Salford is that you can actually make a diagnosis of a GBM based on various imaging characteristics. And if you can make the diagnosis based on the imaging, you can avoid unnecessary CT, chest and abdomen looking for a primary lesion elsewhere. So this is solitary metastasis and subcortical white matter with some edema around it, thin rim enhancement, abutting the Grey-Hot Matty junction, versus a glioblastoma that involves the cortex, expanding the gyrus. So there's an article long time ago that uses what they call a cortical flare hyperintensity to differentiate a metastasis from a GBM. What they find that if you see an abnormality with contrast enhancement, and beyond the enhancing component, if the cortex is flare hyperintense and expanded, this is a good sign that this is a glioma. Whereas metastases tend to have very clean edema around the margins of the lesion. This is just diffusely infiltrating cortical gray matter. So this is a good sign. This one, multiple lesions, synchronous. These are metastases. This one is a meningioma and a meningioma, or you can have bifocal germinoma. So not all multiple lesions are metastases. So recognizing the location of the abnormalities and knowing the diagnosis of each individual lesion, you can put together a good diagnosis, good differential diagnosis. You can have multiple lesions that are syndromic. We know that this assists with neural nodules, this is hemangioblastoma. You can have cord hemangioblastomas here, another one here, and this damaged eye here. This is von Hippel-Lindau. You can have multiple lesions, CP angle lesion, another one on the other side, paracavernous meningioma, falcine meningioma. You probably can guess the diagnosis here. NF2. Ventricular lesion adjacent to the foramen of Monroe, enhances, little nodules here. Cortical lesions. These are cortical tubers, subependymal tubers. Full house is tuberous sclerosis. But you can also get unusual multiple lesions. In this case, you look at this lesion. This affects the cortical gray matter as well. This is very much a glioma, glioblastoma. Here, there is involvement of optic tract going towards optic chiasm, the brainstem lesion. So if you look at this lesion, this is a glioma. What affects the optic tract? The only tumor that affects is optic nerve, optic pathway glioma. Brainstem, again, encephalitis, a tumor. So you will take individual lesions and make a diagnosis. This is multifocal gliomas. Okay, so at this stage, usually I stop the talk. So do you want to continue going through, or?
Yeah, please continue.
Okay, tell me when you want to stop.
Thanks.
So we've done with hemispheric tumors. So the next category will be the posterior fossa tumors. Posterior fossa tumors are slightly different. You've got to divide into adults and a child. And these are the things to consider depending on location. So let's start off with adult intraaxial tumor. When you have an adult intraaxial tumor in the cerebellum, the commonest lesion is going to be a metastasis most of the time. Okay, big lesion, cystic, necrotic, enhancing component. But why is this not hemangioblastoma? You look at the rim here. There's rim enhancement. In hemangioblastomas, the rim tend not to enhance. This is a tumor, metastasis. Versus hemangioblastoma, pure cyst, and enhancing neural nodule. If you see the commonest benign tumor in the posterior fossa in the adult patient is cerebral hemangioblastoma. Okay, so cystic lesion, neural nodule, cyst wall does not enhance. But once you think of hemangioblastoma, you got to think, could this be von Hippel-Lindau? Then you can look for all the other lesions. It can affect the eye, you can have spinal cord hemangioblastomas, they will screen it, and they refer to geneticists for follow-up. Now, once you've done with intraaxial tumors, we come to the next group, which is the CP angle or extraaxial tumor. The majority of these tumors are going to be acoustic neuromas. CP angle mass enhances homogeneously, causing significant mass effect, hydrocephalus. Third ventricle also distended, so the floor of third ventricle is pushed downwards. Ice cream cone, mass extends into the internal auditory canal. Is a good sign. It's also a vestibular schwannoma. That's the commonest lesion. In this case, a second lesion on the left side, and a paracavernous lesion extending into Meckel's cave. This is NF2. You can have a small lesion just expanding the internal auditory canal, enhancing the contrast, again like an ice cream cone. That's a vestibular schwannoma. Or you can have very, very, very rarely a lesion just sitting inside the vestibule or the cochlea, enhances the contrast. This is an intralabyrinthine schwannoma. That's the commonest CP angle tumor. About 80% of the tumors are going to be acoustic neuromas. The second commonest will be meningioma. Meningioma is slightly different. They tend to be butting big and then butting the petrous bone. They don't expand the internal auditory canal. They tend not to extend into it either. They occlude the porus acousticus. Okay. Based on the imaging, this is meningioma and not vestibular schwannoma. Now, the third commonest lesion is the epidermoid. Epidermoid is completely different. They just look like a cystic space. Low on CT, low density on CT, bright on T2, low on T1. They do not enhance. But when you do diffusion weighted imaging, it has got high signal diffusion trace, black on ADC, diffusion restriction, CP angle lesion equates to epidermoid. Now, CP angle cystic lesion, the second commonest will be a arachnoid cyst. They look just like an epidermoid, except that diffusion is free diffusion. Diffusion trace is black, and then diffusion trace is completely black, and on flare it's also black because it's pure fluid. That's arachnoid cyst. That's how you differentiate. Use diffusion weighted imaging. So we've done with all these now. Let's come to a child. What do you get? I tend not to talk about children tumors because my practice mainly adults, but because the second commonest tumor in a child is a brain tumor, the commonest is leukemia, second is a child in a child is a brain tumor, you need to know what are the tumors you can get. And of all the brain tumors in the children, the commonest lesions are in the posterior fossa. And these two lesions are commonest lesions. They represent about 30 to 33% each. And then a mixture of all the other tumors. In a child, medulloblastoma, they tend to be in the midline, solid lesion, may have some cysts, they lie behind the fourth ventricle, and they enhance the contrast. Versus, I show you MR, dark, very solid with some cystic component and enhances with contrast. This must be differentiated from a cerebral astrocytoma. They tend to be of lower density on CT. They can also have irregular enhancement. They can have cystic component to it, slightly lateralized to one side. On T2, astrocytomas are bright. Low on T1, enhanced with contrast. So the difference is that medulloblastoma is a very, very cellular tumor. If it's cellular on CT is dense, on T1 maybe iso, and T2 is darker versus astrocytoma, which is the opposite. So CT is a very, very useful modality for differentiating the two in a child for a posterior fossa tumor. Medulloblastoma is solid, and dense. Astrocytoma is low. Okay, there are not many uses for CT, and this is one very useful way to differentiate the tumor in a child. Okay. One thing about medulloblastoma and most posterior fossa tumors in children, they can seed like hell. In this case, medulloblastoma has seeded via the CSF into the subependymal space, lobulated lesion. They can also seed in the CSF into the spinal cord. And hence, medulloblastoma, before they do anything, before you even touch it, you must always scan the whole neuraxis looking for seeding before you treat or biopsy it. So we've done with two commonest tumors. Ependymoma is next. Ependymoma is slightly different in a child than posterior fossa because it's in the ventricle. Ependymoma is one tumor that looks like toothpaste. When it squeezes out through all the holes, you know there's going to be ependymoma. They can squeeze through the foramen majondi into the foramen magnum. It can squeeze through the foramen of Luschka into the CP angle system. And it enhances. And they tend to be stuck to the back of the brain stem. So choroid plexus tumors next. They are very, very, very rare. Lobulated, enhances homogeneously, looks very much like a ependymoma. Fourth ventricular ependymomas are less common. In children, choroid plexus papilloma tends to occur in the ventricles, whereas ependymoma occurs in the fourth ventricle. And in adult, it's the other way around. Choroid plexus papillomas are not common. And you can also get choroid plexus carcinoma. These tend to be embryonic tumors. They occur very, very early in life, usually less than 1 year old. And they're really nasty, and they can, most of these patients, by the time we resect it, they'll be dead. They don't do well. Okay, let's park this aside. Let's go to intraventricular tumors, the next subgroup. In adults and in child, differential diagnosis is different. We've done this, we've done this. So let's go through meningioma. Meningiomas are commonly in the fourth ventricle. They can be calcified, they can be dark on T2, they enhance homogeneously. So if you take this lesion, park it in the convexity dura, you look exactly the same. It's just that this lesion is in the ventricle. Subependymoma is less well recognized. They are lobulated, big, huge lesions in the ventricles. They can occur in the lateral ventricle or in the fourth ventricle. In the lateral ventricle, they tend to be bright. It looks just like a fluid-filled lesion. A few holes in there, low on T1, and they tend to enhance quite little. And this is quite typical appearance of subependymoma. Versus central neurocytoma, which is a much less common lesion. They're also intraventricular. They tend to abut the septum pellucidum, sometimes abut the lateral wall. They are low on T2, very lobulated lesion, and they can enhance as well. These are much less common lesions, central neurocytoma. This is quite different from the subependymoma I showed you earlier on. But don't forget, very, very, very rarely you can get a metastasis. This was confirmed as a renal cell metastasis in an odd location, very odd, as it was the only isolated lesion. Now, once you come to pineal region, it's a completely different beast altogether. Pineal region tumor can be divided into pineal gland tumors, or coming from the falx, or coming from a tactile plate. Once you have pineal gland tumor, you can divide into primary pineal tumors or germ cell tumors. And germ cell tumors nowadays are divided into secreting and non-secreting. So the approach is completely different when you come to a pineal region tumor. These two lesions look very similar, like I said earlier on, but one is coming from the tactile plate, and the second one is in the falx and the tentorium where they meet, falcotentorial meningioma. They're different. So once you come to pineal region tumor, pineal region lesion, you can first decide, is it coming from a tectal plate? Is it a tectal plate glioma? Or is it coming from pineal region, pineal gland, which is pineal tumor? Or is it coming from the falx and tent, falcotentorial meningioma? So you know where the location of the lesion is. Primary pineal tumors versus germ cell tumors. The way to differentiate is that if a tumor engulfs the pineal calcification, it tends to be a germ cell tumor. If the pineal calcification is exploded, so it's scattered everywhere else in the lesion, it tends to be a pineal origin tumor. That's how you differentiate. This is a pineocytoma. Pineal region lesion enhances homogeneously with a small cyst at the back, histologically confirmed. Now, germ cell tumor. Germ cell tumor is divided into secreting and non-secreting tumors. The way to differentiate is to use your tumor markers, look for all these things. So these are the tumor markers you look for. Placenta alkaline phosphatase, alpha fetoprotein, beta HCG. These are all the things to look for. So germ cell tumors are, the way to approach it is that once you see a pineal region lesion, you think it's a pineal tumor, engulf the calcification, then you know it's going to be a germ cell tumor. The first thing to do is look for tumor markers. Look for CSF and look for serum tumor markers. Divide into secreting and non-secreting. Once you've identified all that, next thing to do is you need to scan the whole spine, look for seeding as well. Okay, so tumor marker, germ cell tumor, pineal tumors are different in that you do not go straight into biopsy. The first thing to do is check for tumor markers. Okay, so that's germ cell tumor. Once you get rid of all the pineal tumors, falcotentorial meningioma, tectal plate glioma, we've already talked about, then we move to the next group, which is suprasellar tumors. Suprasellar tumor, once you see a mass in the suprasellar system, the differential diagnosis between adult and children are different. So for suprasellar mass, the first thing is that, is the lesion above the cellar or is it coming from the cellar? If you see the pituitary fossa being expanded by the lesion and the lesion is going upwards, it's going to be pituitary tumor coming from below, going up into the suprasellar system. Whereas if you have a lesion that is outside and creeping into the cellar, so it's predominantly outside, and you can see normal pituitary can push downwards, this is a meningioma. Then you come to the next one, which is craniopharyngioma and rutherford cleft cyst. Craniopharyngioma and rutherford cleft cyst are supposed to be on the same spectrum of disorder. They tend to be suprasellar, very rarely intrasellar, and craniopharyngioma is divided into there are two peaks. One is in the 5 to 10 year old, and the second one is the 6th decade, and they're slightly different. The commonest type is the adamantinomatous, which is the one with the engine oil appearance, big cystic component. And in craniopharyngiomas, the cystic contents are hyperintense on T1. So if you have a cystic, suprasellar cystic lesion with T1 hyperintensity in the craniopharyngioma is your first diagnosis. But you can also have some small enhancing components to it. Part of it enhances at the bottom here. And one of the clues is that calcification on CT. Okay, they have chunks of calcification in it. So suprasellar mass with lots of calcification, cystic component, T1, iso intense, solid enhancing components associated with it as well. It's craniopharyngioma. Rutherford cleft cyst is another one that's quite not uncommon. It's a cystic lesion that can be low on T1, T2, high on T1 because of the contents. But if it is high on T2, if you find a tiny black nodule at the edge of the lesion, and then little nodules bright on T1, is also another Rutherford cleft cyst. And they said that craniopharyngioma and Rutherford cleft cyst are in the same spectrum of disorders. and thick cleft cysts tend not to have calcification. They tend to be much smaller. In a child, there are three things you think of if you see a suprasellar lesion. Is that a germ cell tumor, craniopharyngioma, or histiocytosis? This looks like a standard pituitary macroadenoma presented with diabetes insipidus. This is a suprasellar germ cell tumor. Any child with diabetes insipidus with a suprasellar mass is germ cell tumor until proven otherwise. And don't forget, in germ cell tumor, the commonest location is pineal region in suprasellar. And if you see a pineal lesion with a suprasellar component, this is bifocal germinoma. This is not due to seeding. The nature of disease that it can occur at the same time. So the relevance of this is that when you have a pineal mass compressing a tactile plate with triventricular hydrocephalus, for neurosurgeons, the first thing they want to say is they want to do a third ventriculostomy, decompress it. But always look at a second lesion. You've got a second lesion here. You cannot do a third ventriculostomy because there's a tumor sitting in the suprasellar system on the floor of the third ventricle. Okay, suprasellar lesion can also be due to optic pathway glioma. So you need to assess the optic pathway and see whether it's actually compressed by the lesion or actually involving it. In this case, the prechiasmatic optic nerves are enlarged, optic chiasms are enlarged, optic tracts enlarged, and it's tracking back towards the mesotemporal lobe. This is an optic pathway glioma. And optic pathway glioma, when a chiasm is involved, they're intimately related with hypothalamus. It merges with it. And optic pathway glioma can be sporadic, can be related to NF1. This is another tumor. Same thing, the whole optic tract, optic pathway is expanded by the tumor. Optic nerves, optic chiasm, hypothalamus, optic tracts, and tracking back towards the lateral geniculate body. Okay, histiocytosis is the other lesion. You think of enhancing lesion in the suprasellar component. No cyst, no angionoia, just a solid mass in there. So the differential diagnosis are either germ cell tumor or histiocytosis. They also present with diabetes insipidus. So syndrome-related tumors. These are the common syndromes that we see. NF1, NF2 are the commonest. Tuberous sclerosis and 1 hippolymph are not all that uncommon. These four conditions are managed at the St. Mary's Hospital. Manchester is one of the 2 NF1 centers in the country and one of the 4 NF2 centers in the country dealing with NF1 and NF2. We have a geneticist only specializing in tuberous sclerosis and one with von Hippel-Lindau in Manchester. NF1 is about 10 times commoner than NF2. In NF1, they can get optic pathway glioma. They can also get other intraaxial tumors. So once you make a diagnosis of NF1, most of the intraaxial tumors are going to be pilocytic astrocytoma. The clue is that you get this high signal in the globus pallidus. These are areas of what they call myelin vacuolation. They're not tumors. There's a clue. Very few things, in fact, no other condition gives you myelin vacuolation. Only NF1 gives you this appearance. NF2. NF2, I think of it as the lining tumors. Tumors of linings. So what lines a nerve, cranial nerves? Schwann cells, so get schwannomas. What lines the brain? Meninges, meningiomas. What lines the ventricles? Ependymomas. So these are bilateral CP angle tumors going to IM, bilateral vesical schwannomas. Spinal cord, ependymoma. Here, in NF2, they also can affect all the other cranial nerves. This is the third cranial nerve, oculomotor nerve, enhancing with contrast. Another meningioma here. So NF2, you can also have multiple schwannomas, ependymomas, and these are not metastases. Von Hippel-Lindau, I showed this earlier on. Cerebellar hemangioblastoma, mural nodule. You can also get an enhancing lesion in the spinal cord. You can end up with cord swelling or tumor serings. Multiple cerebellar hemangioblastomas, tiny dots, and cord hemangioblastomas. Tuberous sclerosis, which I showed earlier on, ependymal giant cell astrocytoma, enhancing with contrast, ependymal tubers and cortical tubers. So syndromic. So you have multiple lesions. If you see multiple lesions, it looks really, really bizarre. You've got to think, is this syndromic? Then you've got to tie all this together and see whether they can come up with a diagnosis. If you remember the common lesions like NF1, NF2, TS, and VHL, those are the first ones you want to exclude. Occasionally you get one of these lesions, nasty, weird-looking tumor in the posterior fossa. But because the appearance is so typical, with this tiger stripe appearance, this is limit duclos. Limit duclos is a dysplastic gangliosarcoma of the cerebellum. And once you see this is a low-grade tumor. And the only reason for treating is because of the mass effect causing hydrocephalus and foramen magnum plugging. But in this particular case, once you identify this, you've got to exclude Cowden syndrome. And what kills them is all the other tumors. Breast cancer, they get sarcoma, thyroid cancers. Those are the ones you want to screen for. So progression of tumor. So come to the end of the talk now. Progression of tumor, interval imaging is required to determine progression. But most of the time now, most of the tumors are actively managed. Very few tumors are watch and wait, unless it's entirely benign things like meningiomas. Once you've treated a patient, you always need an immediate post-treatment scan to form a baseline to see what is left behind so that when it grows, you can follow them up. How you scan these patients determined in the MDT, and it's an MDT decision based on the histology. CT is generally insufficient. You need MR to follow these patients up. I just want to highlight this particular paper that was published by Matt Bailey and Professor Kamali. This was done in 2009, 2010, based on the data from our Manchester Neuro-Oncology MDT. We're trying to make a point that if you make a radiological diagnosis of a primary high-grade glioma, these patients do not need CT chest and abdomen. And we have shown that CT body scans in about 90% of radiological, of all these tumors, 60% were primary tumors, 40% was metastasis. And the radiological diagnosis was high for primary brain tumors. So what I'm trying to say is that if you see a glioma, you're confident it's a glioma, you do not need to do a CT chest and abdomen. So in conclusion, MR is the imaging of choice for diagnosing brain tumors. And the whole differential diagnosis depends on two things: location of the tumor and the age of the patient. You get one of these wrong, you're going to make a wrong diagnosis. So you remember the common tumors like gliomas, metastasis, meningiomas, and cerebral lymphoma. If you play the numbers game, most of the time you'll be correct. Okay? And then finally, every brain tumor is discussed in MDT, and with the combined effort, a diagnosis is usually reached. Soon, is that okay?
Yeah, that's great. Thank you very much. Does anyone have any burning questions? If you have, you can either use the chat or unmute your speaker. Can I ask a question?
Yep.
Any good ways of differentiating between radiation necrosis and recurrent tumor without, using advanced imaging modalities, PET, fusion, diffusion, or not?
That's a very, very difficult case of CVAL. So it's complicated by the fact that tumors can progress, they can have pseudo-progression, they can have true progression, and once you treat it, you also have radiation-induced changes, so it can be quite difficult. So what we have done, I think, is using, apart from standard imaging, we also try to use perfusion to see whether we can characterize it a little bit better. Since I left Salford, I'm not sure how things have progressed, how confident they are in making a differentiate the other two. We did try to use it to sieve some of it out. Some people have also even tried using I think, PET to differentiate it. I'm not sure that works either. So I think it's a difficult question.
Fair enough. Thank you. Somebody's asking about the difference between GBM and hemorrhagic stroke.
Okay, so firstly, as far as I'm concerned, there's no such thing as hemorrhagic stroke. There are two types of hemorrhage. You either have a primary intracerebral hemorrhage, or you have a stroke with hemorrhagic transformation. So when you have a primary ICH, someone has bled, big huge hematoma or small hematoma, is different from a hemorrhagic transformation or stroke when you have an area of infarction within which there are some areas of hemorrhage. So they're quite different things altogether. When you have a primary ICH, my practice is very much, if you see a primary ICH, you must always try to find out what is the cause of it. And never turn around and say, sit on it and scan again and see what happens. You have to find what's the cause of the bleed. Whether it's arterial, whether it's venous, is it a vascular lesion, or is it a tumor-related bleed, or is it amyloid microangiopathy? I tend to go all out to find out the differential diagnosis. So in the acute stage, when acute hemorrhage, you either do an angiogram or venogram to find out what's the cause of it, if it's suspected. If not, do an MR with the brain tumor protocol. If you find a hemorrhage, at the edge of the hemorrhage, there are solid components that enhance your contrast. It's more likely to be an underlying lesion. And the other thing is that when you have primary ICH, most of the time when you bleed spontaneously, there's very little edema around the hematoma. If you have a hematoma and you find there's a lot of edema around it, it usually means that something is sitting underneath it. There's a cause for it. So never ever sit on the primary ICH. Always investigate and come up with a good differential diagnosis before you say, let's rescan it in 3 weeks' time or 4 weeks' time. You must always try to find the cause of it.
What would you say is the optimum timing for imaging, acutely or delayed?
Acute. I always scan acute. If acute hematoma comes to me, if I pick it up, the first thing is that I must know what my differentials are and what's the cause of it. Never sit on it. And if not, I always insist that they scan with MR with full brain tumor protocol and gradient echo sequence to find out what's the cause of the bleed. You think about it, what causes bleed? If it's an AVM or something vascular, you haven't got time, you could bleed again. If it's a tumor, if a tumor is bleeding, that means it could be very, very cellular. It could be a lot of rapid cell turnover. That's why they bleed. You haven't got time to wait. We have a case, I think some time ago, the patient had a bleed in Salford. We waited 4 to 6 weeks to rescan it, by which time the tumor is significantly expanded, a big, huge tumor. So I think once it bleeds, something is going on. You must investigate. Never discharge the patient home and bring it back for a scan. You've got one opportunity to get it right. Do it straight away. That's my approach to it. Some people may disagree, but that's my approach.
So as neurosurgeons, we often don't see the follow-up scan. When we take the acute referral and advise further imaging.
Yep.
Do you find that you miss many things if with the acute blood there when you scan acutely, or you can still see if there's a tumor there?
So there's another whole talk you can have all on blood products alone. So blood products can evolve with time. Now, when you have acute bleed, depending on the stage of the blood, on the MR you can tell what kind of blood products there are, whether it's oxyhemoglobin, or methemoglobin, extracellular. So you can tease all that out to find out which one it is. But the whole idea is to see what else is around the lesion. So for example, if an 87-year-old comes to ICH, first thing is amyloid microangiopathy. So why do you need an MR? Because if I do an MR, I find there's no underlying lesion and there are multiple microhemorrhages elsewhere, full stop. This is amyloid, end of story. So it's very important to get it right the first time round. The other thing is that patients with so-called stroke, hemorrhagic stroke, if you transfer the patient back out into the community of different DGHs, when they find a tumor, they're going to send it back to you anyway. So it's best that you get it done immediately, sort the problem out. I know that that's not really the practice, in a big neuroscience center where a lot of patients come in, but it saves a lot of problems. In Manchester Royal, in Trafford, Wythenshawe, when we have a tumor, we diagnose it straight away. And you will have the feedback, because if we find a tumor, it will come back to you. You see what I mean? The only ones you don't get is when we find amyloid microangiopathy, because you can't do anything about it.
Yeah. Great, that's very helpful. Lots of thank yous coming in. Again, I'd like to reiterate that and thank you for giving up your time on a Sunday morning. Apologies for the technical issues, but we got there in the end, and it was a very good talk, very well received. And yeah, thank you very much. So if anyone else has any questions, feel free to ask now. Otherwise, we'll be concluding there. I think that's a no.
Thank you very much.
Thanks again.
All right.
Thank you.
See you. Bye-bye.